Good afternoon, everyone, and welcome to Support Hospital Opioid Use Disorder Treatment, Shout Texas Echo. Please note that we are recording these sessions for later distribution. Know that your names do not appear on the recording of the session, nor does anything listed in the chat. Thank you all for joining us today. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat function. We love to see everyone's smiling faces, so if you're comfortable and able, we encourage you to join by video, especially for the discussion portion of our session. We invite everyone to speak, but ask that you stay muted unless you're speaking. To mute and unmute, select the microphone icon on the bottom left of your screen. If you've joined on a computer or if you've joined by phone, use *6. You can also communicate with the chat feature to raise questions and share comments. Please note that no protected health information is allowed in either the chat or discussion. During and after the session, the Shout Texas Echo team will send out a link to the evaluation of the session. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. So please go ahead and participate. Our didactic today is on supporting interprofessional addiction care in hospitals. Following that, we will discuss a case presented by Caitlin Roth. We will start with introductions, followed by didactics, announcements, case presentation, and open discussion. Thank you all again for joining us at today's Echo. In the spirit of all teach, all learn, we encourage you all to share your experiences, questions, and insight. We have a small group today, so we'll just go around and do some introductions right now. Dr. Moriartis, can you start off?
Sure. Hey, everybody. Dr. Chris Moriartis. I'm a hospitalist at Del Med, an assistant dean for healthcare value, and I'm a part of the Shout Texas team.
Thank you so much. Dr. Lindsay?
Adrienne Lindsay, I'm the director of the Center for Substance Use Training and Telementoring at UT Health.
Thank you. Ariana?
I'm Ariana Campbell. I'm a PA working in an emergency department in Northern California. I'm also a director, co-principal investigator, and founder of California Branch. And I'm really happy to be here today.
Thank you so much for joining us. Caitlin?
Hi, everybody. I am Caitlin. I am a nurse practitioner with the Palliative and Supportive Care Team at Del Seton Medical Center in Austin, Texas. And I'm happy to be here.
Thank you so much for joining us. Alana?
Hi there, everyone. My name is Alana Bolton. I am the program manager of Support Hospital Opioid Use Disorder Treatment at Del Medical School.
Thank you. Dustin DeMoss?
Hi, Dustin DeMoss. I'm the medical director for Trinity Springs Inpatient Psychiatric Hospital and kind of the spearheading guy over at JPS for our new addiction service line.
Thank you. Cole?
Hi, yes, ma'am. My name is Allie Cole, and I am a substance use counselor for Tropical Texas Behavioral Health. I'm also the OSAR Priority Admissions Counselor for Region 11 of Texas for opiate substance use.
Thank you so much for joining us. Rhoda Hall?
Hi, everybody. My name is Rhoda Hall. I'm with Premier Care. I'm a PAC counselor with OSAR and an LCDC for Ector and Midland counties.
Thank you. Amy Brown?
Hi, I'm Amy Brown, a project coordinator with Be Well, Texas.
Thank you. Emily Ibarra?
Hi, my name is Emily Ibarra. I'm in Houston at Benthob Hospital. I'm the nursing program manager for maternal substance use. Thank you.
Thank you. Christine Celio?
Hi, everybody. I'm Christine Celio. I'm a clinical nurse specialist at the Inpatient Palliative Care Department at Seton, Maine and Del Seton Medical Center.
Thank you. Rocky Payne?
Morning, everybody. My name is Rocky Payne. I work for Health and Human Services in Texas and the Texas Targeted Opioid Response Program. And we're a funder of the SHOUT program in Texas.
Thank you. Stephanie Morelos?
Hi, everybody. My name is Stephanie, and I work for Parkland Hospital. I'm with the Perinatal Intervention Program and our Integrated Family Planning Opioid Program. I'm a licensed chemical dependency counselor and a peer recovery navigator.
Thank you so much. And Mary Ann Forcher? Mary Ann, are you able to? Yeah, there you go.
Hi, yes, this is Mary Ann Fosher. I'm also with Parkland. We have an integrated family planning opioid treatment program, prevention and treatment program for women. And I work with Stephanie. I'm an advanced practice provider, a certified nurse midwife.
Awesome. Megan?
Hi, happy St. Patrick's Day, everybody. My name is Megan Clark. I'm a PA working with the UT Heroes program in Houston.
Thank you. And Sharon?
I apologize. My name is Sharon Shoemaker. I am reentry peer specialist with Abilene Recovery Council.
Thank you so much. And our Echo IT, Angela.
Hi, everyone. I'm Angela Riley. I'm over at UT Health San Antonio. I'm a research assistant, but today I'll be the Echo IT. Good to be here.
Thank you, everybody, and thank you for joining us. So with that, we'll get started with our didactics. Whenever you're ready, Ariana.
Okay, yeah, I'll go ahead and share my screen. All right. Okay, can everybody see that okay? All right, so yeah, thank you for having me from California. I think we actually have exactly the same weather right now, based on what I hear. But I appreciate, this is my favorite thing to talk about. I'm as I said, a PA. I became very passionate about this work and actually worked with Rich Botner for a little while, especially in the beginning, when we founded California Bridge program and really got things off the ground. So I'm gonna talk about what we're doing to create a shared understanding in these interprofessional teams, because that's really where we've landed with what is important, is a shared understanding of why we're doing this work, what we're doing, and how. And I can already tell from what's going on here, like from hearing everybody who's on this call, you already have a lot of interprofessional stakeholders, and that's really, really important. Just so you know, California Bridge, I don't have any disclosures. We are just a program of the Public Health Institute. We're funded through some SAMHSA grants and through the Ford Foundation as well. And all of our materials, we have a Creative Commons attribution, so you can use them, you just have to credit California Bridge. All right, so what I usually like to start out with is just acknowledging the importance of hospitals and hospital emergency departments in this continuum of care for substance use disorders in general, particularly opioid use disorder, because of the urgency of the situation and because this is a frequent site of care for folks who otherwise can't find care. Why? Well, I mean, I think those of us who work in the emergency department or hospital setting know that we've had patients for years and years and years who are struggling with addiction, with readmissions, with repeat ED visits. And when we're not providing evidence-based care, we do see an increase in visits. So there was actually just a retrospective study done, I should have included in here, which showed ED visits for folks struggling with substance use disorders. They have 5 times the amount of ED visits. And for those struggling with substance use disorders, 7 times the amount of hospitalizations. So, you know, maybe it's a stretch, but what could we do if we actually stabilize these substance use disorders, treated them effectively to really, not only helping the person, the community, but also reducing their risk, right? People are coming to the emergency department hospital due to medical conditions that are frequently associated with these substance use disorders. And we know that emergency departments are the ultimate safety net. It's the only place where my folks can come where they don't need to have all their ducks in a row. They don't need to have their ID or their insurance card, or they're often easily accessible. In my town, there's one bus, but it does stop off at the hospital. Like when we say the bus drops off, it really does. Like at my hospital, there's one bus and it does drop off at my hospital. So it's also the only setting to offer all hours access. You know, we can do it all, right? Acute psychiatric stabilization. We provide navigation to ongoing care. And it's really this critical connection to folks who are the most vulnerable in my population and in what we've seen, not only in California, but across the country. So in California Bridge, we have scale. Folks have said that the reason we have such scale is because my 3 directors and I just never believed we couldn't do this, but we are creating universal access in emergency departments and hospitals. And what that means, and our dream is that when somebody, like for example, somebody has chest pain, they know that they should go to the emergency department or hospital, right? That's just a shared understanding. They cut their hand really bad. Okay, where do you go? You go to the emergency department. We want folks to know that if they are struggling and they say, okay, now's the time, they don't have to go through a super complicated system to figure out where to go. We want to capture them in that moment where they know they could go to the local emergency department or hospital if they have a, if they have a condition which requires hospitalization, and they will get evidence-based high quality treatment. What's funny is when I say that, people think, doesn't that already occur? And no, right? We frequently were giving the list prior to my hospital doing this project, and I know that we were not alone in that. So what we're doing in California so far, we are implementing in 208 hospitals, and we just received funding from the state. So our state legislatures set aside money to fund Navigators in every single hospital in the state. So we're talking 300 hospitals. And I heard there's a lot of Navigators on this call. We call that the secret sauce. We know that when somebody's from the community, of the community, by the community, and working in that hospital or emergency department setting, it makes a huge difference. And we're also now assisting hospitals in 35 states and growing across the US to do similar programs. So it can be done anywhere, and that's the idea. And we've been doing some support for folks in Texas for a little bit. I do have a lot of amazing people I've worked with in Texas. So I'm very, really happy to be on this call. So we do know, and this is the shared understanding that's really important across all of the disciplines in the hospital. Addiction is fatal. 100,000 people died from drug overdoses in 2021. And we have this enormous burden of disease in the country. And so when I hear people say, well, I don't really have that in my community, it's there. They may just not feel safe disclosing it to you. So, and that's what I actually said that when I started my program more than 5 years ago. I said, ooh, I don't really think we have a problem with opioid use disorder in my rural community. And boy, was I wrong. And we've been able to influence care in our community greatly. So here's a question. Why start treatment in the ED? And I know that I have a lot of hospitalists here. I have a lot of folks who are working in outpatient settings, but this is an important message to get out, that this needs to be universal. So we need to treat withdrawal as the emergency it is. I was trained that opioid withdrawal is not an emergency. Alcohol withdrawal can be, benzo withdrawal can be, but opioid withdrawal, people are fine. And that's just simply not true. And we'll talk a little bit about that. Emergency departments are certainly a frequent site of care for folks with opioid use disorder. These are folks who are often otherwise not engaged in care and don't have access to resources. And again, we have that 24/7 access to care. And then, I'll talk a little bit about the study, but treatment in the emergency department, we know from a randomized controlled study done in published in JAMA in 2015, that treatment in the ED doubles the likelihood that somebody will be in treatment in 1 month. And that treatment decreased that person's risk of dying from any cause by more than 50%. So this is essential. So addiction is a medical emergency. Why? Overdoses. So where do folks go? We say this is an overdose epidemic. Where do folks go when they overdose? They go to the emergency department. Frequently, they'll get admitted. So this is absolutely essential to have a program. And in this slide, I want to highlight, this was a study from Scott Weiner he published in Annals of Emergency Medicine, and he looked at patients after non-fatal overdose. So folks who were reversed, came to the emergency department, subsequently left either against medical advice, discharged, etc. And for folks who did not receive buprenorphine, who did not receive treatment for their opioid use disorder, there was a high rate of mortality after that non-fatal overdose. And I just want to call your attention to that the first skyscraper there. That's the first day after a non-fatal overdose. And these are folks who then with fatal overdoses after that. So what we do know is that 1 in 20, so 5% will die within a year. And of those, 1 in 5 will die in the first month. And of those, 1 in 5 will die in that first couple of days. So this is really important to treat, to offer treatment, to give resources. And in fact, my hospital, we've come up with a post-overdose protocol to address this that our nurses are involved in. So if somebody's going to leave, prior to their discharge, which we know is very frequent, we make sure they have naloxone in hand. We make sure they have a prescription of buprenorphine. We make sure our navigator is involved and does follow-up. So there's a set of things that we do for this, knowing the fatality rate in those first few days after they leave. So it's really important. Just like we look at risk factors, we look at heart scores, for chest pain. This is really important to have a plan after a non-fatal overdose. And again, we've talked about this, but addiction is very treatable. So, we know just by giving the right medication at the right time to the right person will double their likelihood of being in treatment at 1 month. I can tell you in my emergency department, this was Gail D'Onofrio's article, like I said, that was published in JAMA in 2015. And it was 78% of folks who were in care at 30 days who were given buprenorphine in the emergency department. My setting, I have more of a closed system, so we were able to really take a good look. We have like a 97% follow-up rate. We have, I think it's 86% who are still in treatment at 1 month, and 50%, more than 50% of the patients we've ever treated from the emergency department are still in treatment. So we know there's these historical barriers to access, right? So I hear a lot of folks say, well, it's the emergency department. We have our hands full. We have COVID. We have all of these things. Yes, but there's these huge barriers to access. And again, we see significant increased ED utilization and hospitalization with folks struggling with substance use disorders. So the barriers that unfortunately have really evolved over the years with these long distances to treatment in a lot of rural communities like mine, long waits for treatment, 3-6 months in many areas. The list, here's the list, go find yourself treatment, pull yourself up by your bootstraps, behavioral health requirements. We all know this. If you have depression, they'll say, oh, we don't see people with depression. It just has to be a substance use disorder. Or if you have a substance use disorder, we won't treat you for your depression. So the people who are the most vulnerable don't get treatment. And then of course, stigma, and then making treatment contingent on urine drug screens. We don't actually even do those to start treatment in my emergency department. All right, so why start in the hospital? And I'm probably preaching the choir here because I have a lot of hospitalists, but 67% of hospitalized people who use drugs say that this is their moment that they'd like to cut back or quit. And they do at this moment have a fear of bad outcomes. This is one of those moments. They're also in a place where there's increased support, so it's a great opportunity. And if they're treated with respect and kindness, they'll feel more comfortable doing this. And then we can actually treat withdrawal. We can prevent folks from leaving against medical advice, linked to care, and decrease readmission rates substantially. So, and that's how to talk to your, certainly your executive, stakeholders. So, and we do know when we initiate buprenorphine in the hospital setting that we significantly increase their linkage to care. So you can see here linkage versus the detox model. Folks who receive medication and are linked to care have an excellent follow-up rate. And what I can tell you is buprenorphine is very safe. This was a bunch of my partners who published this on high dose buprenorphine and actually found that we were able to give pretty high doses of buprenorphine, and we just see this ceiling effect on respiratory depression. You can see who was treated with the different doses, and we had 138 patients in this study who were treated with more than 28 milligrams of buprenorphine. So we are able to treat rapidly, and in the emergency department setting, certainly feel comfortable with giving decent doses of this medication. So the model that we developed to really include everybody, right? It's rapid evidence-based treatment. We make sure our physicians, PAs, nurse practitioners, OB, our OB partners, hospitals, everybody's on board with knowing that we need to treat rapidly and we need to treat with the right medication. We need to make sure folks are connected to ongoing care. Lots of navigators on this call. These are, again, secret sauce that really make patients feel comfortable. And we want to make sure people are treated with respect and a harm reduction type of culture. So again, evidence-based treatment is really important. So giving buprenorphine. Methadone works as well, so I'm not against methadone. We can just treat rapidly in the ED with buprenorphine, and it has a great safety profile. So we have this is we have an algorithm that we use. It's pretty simplistic. I'll be honest, we're updating it, making it even simpler, and also including how to treat precipitated withdrawal on it, which I'm happy to discuss. But the simplistic protocol, you want to keep it easy, make sure you're treating with adequate doses. And then what we do know is when you do this, when you do the right thing, just giving the right medication at the right time, the number needed to treat is, this makes it obvious. So you can look at the number needed to treat for all sorts of conditions, which are standard practice. So, just aspirin for primary prevention of heart attacks, how many we need to treat to prevent stroke, antibiotics for folks with cirrhosis, upper GI bleeds, proton pump inhibitors for upper GI bleed. But the number needed to treat for buprenorphine for opioid use disorder, 1.4 to save life. So, this is really, having a low threshold approach can make a big difference. And, like I said, we've talked about connection to care. I usually like to talk a little bit about navigators. We call them substance use navigators. We're actually changing the name to bridge navigators because we're going to do behavioral health navigation as well. But really, our navigators are essential at every step in somebody's journey, including pre-contemplation. So when folks are considering treatment, many times they'll reach out to the navigator. Navigator will meet them in the ED lobby, or even sometimes navigate them if they don't want to come to the ED to the right place. And so they're the ones that are there for the patients to help facilitate high quality treatment. And then culture, we want to make sure we have a welcoming culture. I just did an entire stigma campaign for my nurses, which was extremely effective. In fact, the feedback was the nurses said that this anti-stigma thing that we did with a perspective taking exercise, they felt changed their career and changed their life, which I thought was pretty good feedback. So we did a perspective taking with a navigator. We talked about the neurobiology of addiction, and then we talked about the program that we're doing, and it was extremely impactful. So please, engage nurses early with evidence-based information because it can make a huge difference. We have published on what we're doing, and probably the biggest one is this rapid adoption of low threshold buprenorphine treatment. Our first 52 hospitals, 100% of them were able to implement this program within a year. And many of them are now champions. Many of the first 52 sites that we had emergency department and hospital champions who are now, statewide champions, and some of them are giving talks all across the country. But in the first year, we were able to give, it was more than 7,000 patients who were given buprenorphine. And I don't think it's published yet. UCLA just did a study of all the programs in California, and we had the most amount of patients treated through the California Bridge program. And that is because emergency departments can pivot quickly, hospitals can pivot quickly, and we do have this great number of people who need this treatment. So we were by far able to implement quickly to treat the largest amount of patients, and we did not receive the most funding in the state. So it's interesting to look at what emergency departments and hospitals are able to do. So the impact now, this is just through September 2021. I actually think our numbers are probably almost double this now, but we were able to, almost 24,000 patients where medication was either prescribed or administered. And our navigators saw almost 78,000 people. So this is opportunity where we're able to help somebody on their journey. All right, so that's it. Like I said, that what's been really key for my program has been lessons learned is involve the nurses early. And I can tell you that we've evolved now. That's me. Feel free to reach out, call, email. I'm very passionate about this work. But, and I'm going to take this off of sharing here pretty soon. But what I can tell you is the more people you involve early, the less headaches you have later. And so I have provided guidance to my surgeons. I have a large inpatient program going. And ultimately, I developed a substance use disorder committee to drive best practice. And it's an interdisciplinary committee where we have folks from outpatient, inpatient, physicians, PAs. We have nurse practitioners. We have population health. We have executive leadership there. We have quality improvement. And we all get together and drive better care and hold some accountability in our hospital for treating people who use drugs with evidence-based care and with dignity. So that is my presentation.
Thank you so much, Ariana. This was a great presentation. And are there any questions from our Learning Network?
Ariana, good to see you again, and thank you for this excellent talk. So we're at JPS. We have very similar, very similar program, albeit in the early stages of what y'all have done out there. My question is, we're running into stigma left and right, and we're trying to stomp it out with education, but we have a limited number of supplies, essentially, limited number of people doing it. What were y'all doing to help with the stigma approach? How did you get it kind of rolled out? And you know, it sounds like it was very well received. And did y'all do that, some of the stigma approaches to your providers and other clinicians?
Yes, it's a great question. And we struggled with this for years because naivety. I thought, well, we're going to give the right medication and people are going to get on board because it works. And it works quickly. I call it the Nursemaids Elbow of emergency medicine addiction treatment. Like, I can give it in triage, somebody gets better in an hour, and that moment like completely changes the trajectory of their life. So I thought everybody was going to jump on board and be like big, you know, advocates of the program. And, you know, 3 years in, we have naloxone in hand. We hand naloxone to patients. And I had nurses who thought that this was enabling people by handing somebody who just almost died from an overdose by handing them naloxone. And I thought, I failed. So I looked into the research, and for stigma, the most evidence-based thing you can do is this perspective taking exercise. And so what that so what we did is I actually got my nursing director in the emergency department on board, and I got the OB nursing director who actually I made a champion. So she got on board. Those two departments required the training of their nurses in addition to their critical care training. So they did this on a skills day, and it was like a setup. The very first hand went up the very first day, and it was one of our unit clerks who I love. But she said, I don't understand why this is critical care. We have paramedics come, we have we have the ICU come and teach us how to do critical care procedures. How is this critical care? And I just it was like a setup. I just presented the evidence. And so all of these things that you're learning will apply to very few, but you can do this one thing every single day that will save lives. And this is how you do it. And it was like, people were in tears by the end. That, like, people said they couldn't believe they didn't do this. And I think it's because it was a 2-hour session. The first 45 minutes were my navigator, who very bravely told her story. So it humanized this to somebody who they knew, and they didn't think fit the part, right? Oh, it couldn't be you. You couldn't have lived these crazy things. And it was done in a question and answer format. So it was done in a professional way, but with allowing her to tell the parts of her story that were pertinent. Questions and answers were allowed from the folks who were attending. And then we did, the next hour was, we have somebody who does this great talk on the neurobiology of addiction, and related it back to my navigator's story. And then we said, and this is what we're doing to treat this and why. And that 2-hour session was, I wish I'd done it 5 years ago. I mean, I just didn't know enough then, but we had physicians attending from different departments. We did a wide, kind of wide reach with marketing. And now we've been asked to, take like the dog and pony show on the road. So we're going to go out to the clinics and just to create that shared understanding, because stigma, in the end, the medicine part's been easy. The stigma part has been really difficult. And we're also, and California Bridge, we're within 6 months, we'll have this. We developed a learning management system tool that will be free and can be adopted by any institution for nursing driven education. And it's 3 modules and 1 is specific to stigma. And it's going to be required of every nurse who works there and every nurse who's onboarded. We now also require X waivers of all of our emergency department providers. So we've gone that direction where this is just like normal, easy care. Does that make sense?
Absolutely. That's amazing. Fantastic. Thank you very much.
Thank you. I see a question from Megan. Did you want to?
Oh, yeah. So you have the ER start them on Suboxone and then refer to you for ongoing care. How's a typical patient scenario go? Oh, I love this question. This is fun. So I work in the emergency department, and I have a navigator. And what the first thing I did not have a navigator when I started this program. The first thing I did is I just got 4 PAs X-waivered. Like, that's all I did. And we had a pretty successful program for the first year. And it took me 6 weeks to set up. So just so you know, I always say start early. You don't have to have all the parts in place. You don't have to have decreased stigma just to do the right thing. That being said, what it's looked like for 5 years is for uncomplicated withdrawal, we put signage up so that people can tell us they are in withdrawal, right? Because people are coming in for like nausea, vomiting, you know, all of these other complaints and not necessarily telling us they were in withdrawal. So we put signage everywhere in our ED, and it's classy. I think it's classy signage. So allowing folks to disclose a very highly stigmatized condition. And what's funny is when I put up the signs, the nurses are like, what are we doing? So open to conversation. And then, so somebody can come in, see the signage, hopefully feel comfortable telling us what's going on, or have heard from family or friends that they could tell us. And then we assess their withdrawal very quickly. We don't do any labs. We don't do any urine drug screens. We simply assess their withdrawal. I'll say, do you feel really sick? And do you feel ready for buprenorphine? And most patients are this is very easy. And if they say yes, we administer buprenorphine, sublingual medication. If we're busy, when we've been really impacted with COVID and psych and all the stuff we've seen in the last couple of years, we will treat them in triage if we need to, and we will administer the medication. We keep an eye on them for 45 minutes to an hour. If it works, almost always it does, our precipitated withdrawal rate's less than 1%, then we give them another dose. We usually bring them up to 16 to 24 milligrams, depending, but most uncomplicated patients, we discharge them with naloxone in hand and a prescription to get them through to their follow-up appointment. The Navigator has made arrangements. We started with one primary care physician who got their X waiver. That's how we started our program. We now have 3 clinics, all based in primary care that we refer to, and they all hold a 9 a.m. Time for the ED patients. And so if our Navigator's not there, they follow up at whichever clinic of their choice at 9 a.m. the next day, and we just send them a message either through fax or through the computer, depending on the clinic. And then our Navigator will reach out to them and make sure their needs were met, they were able to make it to their appointment, and if they had transportation difficulties, make some other arrangements as needed. That's what it looks like. And we treat about 200 patients per year. It's still like less than 1% of our patients. Our volume in our ED is 30,000 per year. But we see somebody almost every day and successfully treat people. And we also treat post-overdose. So in overdose is reversed, we'll give Butte and prescribe it and naloxone in hand. So we now do similar evidence-based treatments for alcohol. We've even embarked on some stuff for methamphetamine. So we're like, what can we do? Because this was great. So now we've seen different things that we're able to do. We're trying to improve our behavioral health options as well.
Ariana, thank you. As you mentioned, you met early with Rich, and I know your program really served as inspiration and model for Shout Texas and what we're doing now. And you remain, a couple years ahead of us, and have spread to so many hospitals. The results you showed were so impressive. I actually don't know the answer to this. I probably should ask you in private, but I'm gonna ask you in front of everybody. Sure. Give me a sense of the scope or scale, like how much money did the state give you in order to spread that fast? And how big's your team?
Yeah, okay, so we started out, what was our first grant? So first of all, we didn't have a grant to begin with. There was like the 4 passionate people, actually there's 5 of us who just started cold calling hospitals. And by the way, they told us we were crazy, many of them. One of my ER docs now is running a clinic, an addiction clinic. So anyway, so we had no funding initially. We received, I think a few $1 million to start the program. And the first round of funding for those 52 hospitals, I think it was 17 million. And we gave the money to hospitals. This was not for us. We gave the money to hospitals to start their programs. We funded, and this is critical, we funded Navigators. I think we gave like $100,000 for Navigators. And we gave another, there was some overhead fees and stuff like that for equipment to start the program. And then, so it was like $150,000 to each site. And this is in our article, by the way, in that annals, we full disclosure, like you can see how we did this, but we also funded champions. Now in our second round, we got funding from the state. So the first round was SAMHSA federal money. The second round, the state set aside, it was, I think it was 10 million. I should know this. No, it was $20 million to give to sites. And that didn't come to California Bridge. That only came through the state, and the state funded $100,000 for 208 hospitals to do this. I think it was $3 million because there was some overhead. And anyway, so they funded all of these hospitals to do this for $100,000. but we didn't fund champions, and it was not as robust when we did not have protected time for champions. So this next round, we're acknowledging that, and we're going to fund champions again. And it doesn't take that much. I think if you funded champions for some protected time, a couple hours a week, 4 hours a week, it's just allowing that protected time to implement was, that's how we moved fast. So does that make sense? So that's what I recommend. And this next round of funding for every hospital in California is $40 million that the state set aside through the state budget. That's coming through soon. It hasn't been completely, well, it's not out yet. So we're doing the RFP, I think will be for all the sites will be in, I think in 2 months, but yeah. So there was an investment through federal monies going to hospitals, and there was money from the state going to hospitals. And then the biggest proponents of this program were California ASAP and the California Hospital Association. Those were the two that were really saw huge value in this and pushed it forward.
Thank you. I appreciate the detail. It's impressive.
Thank you so much, Ariana. This was awesome. I just want to quickly take a minute. We have a new hub member who's joined us. Dr. Ramesh, would you like to quickly introduce yourself?
Hi, I'm Jan Ramesh. I'm one of the assistant professors of internal medicine at Del Seton. So thank you for having me today.
Thank you so much. We'll now move on to announcements. Echo IT, if you could please share the announcements. Thank you. So Be Well Texas is a welcoming environment with caring professionals who are ready to help people start or continue their journey towards recovery. Be Well Texas is committed to expanding equitable access to compassionate, evidence-based treatment and care for substance use disorder throughout Texas. Next slide, please. From now on, when you sign up for one of our ECHO sessions, you will be automatically included in all our sessions. You will never have to miss any of them. Next slide. The Be Well Texas Clinic offers high quality treatment for addiction recovery at low, no pay or self-pay insurance, so all patients are accepted regardless their ability to pay. Next slide, please. Our next shot echo is on April 21st. We have some exciting speakers lined up, so please do join us. Next slide. So the next Texas Substance Use Symposium is next week on March 24th and 25th. Please do remember to register. They have virtual as well as in-person options. Next slide. And thank you. So we'll now move on to the case presentation. Caitlin, you can start off whenever Echo ID pulls up the case.
All right. Hi, everybody. So I'm going to be presenting a case that I was involved in about a year ago or so as a palliative care provider. And just a little background, I have been a palliative care advanced practice nurse for the last 3 years. I'm going on 3 years. I'm also kind of involved peripherally in our inpatient Suboxone team, B team, and have been involved with that team since I was a student before I even got my job here at Del Seton. And so I do have a special interest in kind of the intersection of palliative care and working with folks with substance use disorders. So whenever we get a palliative consult that comes through, that's relevant, I do try to work with that patient and family and do what I can to support and advocate for those patients and families. The case presentation that we'll cover today, like I said, it was a young man that I worked with about a year ago. The questions that I would like to address, kind of two-fold here. One is how to effectively navigate advocating for a patient's or family's needs when there are other specialties or other healthcare team members that are demonstrating bias or stigma that may be impacting patient outcomes or limiting treatments. Especially if we're thinking about consulting providers who we may not have good relationships with or might not work with on a day-to-day basis. Secondly, have any of y'all ever initiated an ethics consultation in a situation similar to this, and what was the outcome there? Okay, so to go through the case itself, the patient's reason for admission was altered mental status. He was found down by his roommates. He was critically ill when he got to the hospital and was immediately intubated and not able to participate in decision-making because of how ill he was. His father, his next of kin, did report that patient had been complaining of hemoptysis for 2 days prior to that admission. Dad was living out in California at that time, but they did have a supportive relationship. Past medical history, again, because he did arrive in critical condition, his past medical history was a little bit limited. He did have septic carotid pseudoaneurysm repair a few years prior to this admission, and then multiple cerebral abscesses that were drained, I think 2 years prior to the incident where he was admitted this time. He had a remote MVC, I think 10 years prior, resulting in chronic back pain, which precipitated his substance use disorder. No home medications were available on his admission history and physical. You can see here a list of his medications that he was on while he was inpatient. Most notably the antibiotics that were started right away. And then he also was requiring multiple vasopressors to support his blood pressure because of how critically ill he was. So for his social history, he was living with a roommate. At the time of admission, he was not connected with a primary care doctor, a mental health support, or addiction medicine support. He was not married, did not have children. His legal next of kin were his parents, who were divorced, both living in California. His father was also working as a physician at the time. He was not insured. At one point in time, he was receiving our kind of Travis County support called MAP, but that had expired a few years before his admission, or a year before his admission. Both of his parents were very supportive over his 10-year history of substance use, kind of treatment. He was not employed, but had previously worked in the mortgage industry. He was also, had training as an EMT. He was a high school graduate. Psychiatric history, he had struggled with anxiety and depression for many, many years. He had been connected to psychiatry in the past and had trialed a variety of medications, but did not like the side effects. Based on my chart review, this is all kind of gotten from chart review. I wasn't ever able to have the opportunity to talk with him about these things myself. He did also have experience in inpatient treatments for his substance use disorder, both a 30-day and a 60-day program, I believe, and had taken, I believe, Suboxone in the past, but was not currently taking any type of medication for either psychiatric illness or his substance use disorder. So for kind of a summary of his hospital course, He ended up having a very, very long and complicated hospital stay. So I'm really going to focus on time of admission until, the palliative care team was consulted and he was eventually transferred to our other hospital in town that had more advanced cardiac ability to care for him. He presented as a code stroke after being found down. Like I said earlier, he was found to be in septic shock and bacteremic. He was also found to have mitral and tricuspid valve endocarditis with large vegetations. He had multiple septic emboli, both causing an ischemic stroke and empyemas, which required bilateral chest tubes. As y'all can see, he was incredibly ill. We were consulted to help establish the patient's goals of care. About a week after his initial presentation to the hospital, he had been on appropriate antibiotic therapy during that time and continued to deteriorate really. At the time of the palliative care consultation, his legal next of kin, his dad, was still very, very hopeful that we could do everything possible to save his child's life. Eventually, our CTVS team was consulted as well to consider this patient for a valve repair surgery because he had failed antibiotic therapy and continued to worsen despite all of our efforts. He was eventually transferred over to Seton Medical Center, which is where we have our advanced cardiac therapies available, but that was almost 2 weeks after his initial presentation here at Dell Seton Medical Center. When I checked PMP, just preparing for this case, he did not have any historical data available. I was wondering if it was because he eventually did pass and maybe they deleted people after they had passed, but I found that there was not anything available for any of my other patients that had passed either. Let's see, sorry. So this kind of just covers other things that took place over that time while he was here at Dell Seton. He was evaluated by infectious disease and neurology to determine, what the next best steps are. Neurology felt like he was, safe for a valve repair surgery. The critical or CPTS folks did not feel like he was an appropriate candidate because of his recent IV drug use and wanted to talk to him in person before they offered any type of surgery. We did talk about the idea of an ethics consultation, but eventually before that ever took place, he was transferred. And this is just his, past substance use history. I really didn't have a lot of information there because I couldn't have a one-on-one conversation with him and that his chart review was limited. But he did have a 10-year history of IV heroin use that we did know about.
Thank you, Caitlin. So I guess to summarize what I'm hearing, a young man, I don't know if you mentioned his age. I imagine a young man.
He was 30 years old.
Okay, so a 30-year-old man who's critically ill on mechanical ventilation, has both left and right-sided infective endocarditis with MSSA, metastatic infections, including continuing to have septic emboli to the brain. and neuro and infectious disease and you and the team all say his only chance is he needs, you know, these valves replaced, which we would do for anybody. But the surgeon who could perform that is declining to do so. And the sense was that it was based on bias on the fact that he had used IV drugs, not based on his actual medical need for the procedure. Is that where we're at?
Yeah, I think so. I guess the only other thing is like the CTVS surgeon that would offer the surgery, never, to my knowledge, never actually like came to the hospital to evaluate him in person. And so this was all kind of happening from afar and over chart review. So I think that also complicated things a little bit.
Yeah, really frustrating situation. I've certainly found myself before too, where it's like, man, I wish I could perform heart surgery on you. I cannot. And so we're, you know, we have to work with our colleagues. And I think Dr. DeMoss really set this up well with his question, you know, earlier in the hour about dealing with stigma. We heard from Ariana about some, you know, kind of systematic educational ways to address it. But I'm curious, just from the group, does this resonate? Others have similar experiences as Caitlin, and any insights on how to help navigate and keep the patient's needs centered when you're hitting these type of issues?
So one of the things that we've done here is, as part of the shout service that we're doing, we've hit all departments, surgery, OB, Jerry, you know, every department that will give us 10, 15 minutes, we go there, and we ask to come back, you know, at least every 6 months, if not more frequent. We go to the attendings, we go to the residents during that didactics, and on the consult service, even if a patient, you know, comes in, they're intubated, we can't really examine them very well. If they have a history of substance use, we ask if the surgery team wants us involved, and we stay on the case. We don't give recs and then sign off. We stay on. That way, if something does come up that we can even potentially intervene on, such as a heart valve replacement discussion, we get in those discussions as frequently as possible. So that's what we're doing here.
Yeah, thank you for that example.
I'm curious, like hearing this case reminds me of why we actually formed a substance use disorder committee, because we have a stroke committee, sepsis committee, and we developed a substance use disorder committee because what we found were that there was these decisions being made by people who had no knowledge and unfortunately had a high degree of stigma, and this is somebody's life, right? But I'm wondering if you have representation on the ethics committee too, like if there's somebody on the ethics committee who had, you know, who has a background in substance use disorder treatment.
You know, I am not sure if we do have anybody that has that experience on our ethics committee. Christine Celio, you're on our ethics committee. I don't know if you have any insight there, but I mean, that would be a great idea.
Yeah, I know over at Seton, Maine, we have at least one individual who is ex-waiver trained, Melanie Palmer, and I don't believe we have any others. That's definitely an opportunity there.
This is Emily from Benthob. One of the things I found, you know, it's a work in progress for sure. But I practice in similar places like y'all, where there's just like so many teams and so many services. And what we are trying to do is just let them know we exist. Like sometimes they don't even know that we're there to help. And so I work with pregnant women mostly. So luckily, 9 times out of 10, they'll come straight up to us from the emergency room, but it just depends on what's going on. But really just kind of getting the word out that, hey, we exist. One of the other things I try to do is like be very accessible. So literally give them my cell phone number. My work phone number goes to my cell phone. Like anytime we will be available to like help. And obviously, thankfully, we haven't had something this extreme as this case, which is a big deal, but we still have had some pretty bad outcomes with delays and then like precipitated withdrawal, and we could have intervened and done things sooner. And then yes, the champions has been huge because like our addiction medicine psychiatrist who's inpatient and outpatient, he has really helped be that bridge too, because he's in the emergency room. And then he also works with us on the OB side. So that has been really cool to have that bridge. And so like recently he was out, and luckily he communicated to his team who was covering, and we had like 3 women come in withdrawal that week he was out, of course. But luckily his team, because a lot of people are afraid of pregnant women, as y'all know, they don't want to touch pregnant women. And so they, yeah, right there, got a hand up. So luckily, even the docs called me and said, like, what do you think of this? And so that, just knowing they have a resource, and Dr. Ojeda gave them my number, and they're like, call Emily, she can help facilitate something. So anyways, just letting people knowing you're there is huge, and being as accessible as possible. The stigma is like a huge cultural shift, but I think a lot of times, obviously it's ignorance, they don't know what they don't know, but I think a lot of times people just aren't, they feel helpless and don't know how to take care of our patients. And so I think giving them someone that can help is like huge for them. They're like, oh yes, let's just call.
To piggyback on that, Emily, as we've primarily done a lot of education on the inpatient side, but a lot of folks, OB especially, are begging for like, hey, I'm in the clinic, I'm kind of all alone out here. So what we've started is a Butte buddy system where myself, our shout team, our clinical champions, we go through a rotating call every week.
That's awesome.
And that way the clinic folks can say, oh, here's my Butte buddy, and they give us a call, and we walk them through those first initial doses of buprenorphine for their patients in the clinic setting. So,
and I'm sure they feel like so relieved to have you there to like, or one of your teammates to be like, okay, we have someone can call to help us out with this.
Exactly. And our Butte buddy system, it's myself, one of our psychiatric PAs on a consult service. It's the chair of our ER. It's multidisciplinary. So it's not always somebody saying, oh, I'm just going to call psych. They can do it. No, your buddy across the hall from you in the ER can do it as well. That's your buddy for the week. So
yeah.
I love that. And one thing I'm hearing from both of you is being able to draw on other experts, which sounds like you've done, Caitlin, but both addiction expertise, Butte expertise, but infectious disease. I oftentimes sick Dr. Mondi on them. I'm like, look, I don't have credibility with you. Dr. Mondi is going to come tell you that they need this done. And that could be helpful. The other thing that crossed my mind as you were talking about this, I just like Googled, because I know that there's a lot of literature out there and discussion around patients who use drugs and heart valve surgery for infective endocarditis. And one of the first articles that comes up is from the Journal of Cardiothoracic Surgery, which says from this year, which says these patients must be treated aggressively, blah, blah, blah. And so just once again, to remind people, use external sources, right? So it's not me saying so. The Journal of Cardiothoracic Surgery says so. Are you not as good of a surgeon as those guys? That works too, by the way.
I love that. So that's actually what I do at my hospital is I send, if something happens, I just send the evidence because there's so much evidence. Like I remember somebody saying, well, how do I look up buprenorphine in the ED? And I said, just look that up. And they said, oh my gosh, there's like hundreds of articles. I said, yes, there's a lot of evidence. So that's really helpful. And I like that approach. I'm doing that right now with a surgeon who thinks you have to stop Bupe to do surgery. So I sent actually his own organization, his own society's recommendations, which are to not stop Bupe. So
thank you so much. Dr. Moriartis, would you like to just quickly give us a summary?
I would, although I saw John unmute for a second. John, share, and then I'll summarize whatever time.
So many great points came up. John here from Community Care and the Shout team. I think team is so important. And I'm going to put a link to an article that just came out describing a multidisciplinary team that gets together every month to review these cases. In my experience, I think everything was done in this case. It could have been done. Often early on, structural heart defects is the reason for surgery. So I think involving cardiologists, cardiothoracic surgeons, and social work early on is key. Just reiterating high points people already made. And the literature is there too for how to set up these multidisciplinary teams as well when you're talking to leadership at the hospital, saying maybe there's an investment that needs to be made here that can reduce length of stay or reduce bounce back. So thanks everybody, great case.
Thank you, John. That was a nice summary. So today we had what I found to be a really inspiring discussion, an example from Ariana about what they've been able to do for California Bridge, expanding across the state, truly remarkable. And we then had a nice discussion. We actually probably could talk for at least another hour on this topic, but about how to continue to nudge folks and address stigma amongst our colleagues, and using a team approach, using evidence, external evidence is key. So thank you for that conversation. And thank you all for joining us this week on ECHO, even despite spring break. This is a great turnout and discussion. Thank you all.
Thank you everybody for joining us. As a reminder, to earn CME and CNE credits, please complete a post-session survey using the link in the chat. We look forward to seeing you all at our next session, which is on Thursday, April 21st. Have a great rest of your day. Thank you.